Hello, everybody, and welcome back to BioSC 140 Human Physiology. This video is going to cover S4P1 Part 3, the final video for renal physiology. So let's get right into it. ADH maintains blood volume by enhancing water reabsorption. So first off, what is ADH? ADH is a hormone, and it's got a bunch of names, and you need to know all those names. You need to know those names for my test. You also need to know those names for your future in healthcare, because all of these names are common. You might see a vial that's labeled vasopressin. You might see a vial that's labeled antidiuretic hormone. You might have a colleague use any one of these abbreviations. So antidiuretic hormone, abbreviation ADH, also has another name called, which is vasopressin. Vasopressin. Where does it come from? Well, it's produced in the hypothalamus, but it's released from the pituitary gland. So produced in the hypothalamus, released by the pituitary gland. When there's an increase in osmolarity in your body, it will increase ADH release. So increase in osmolarity, increase in ADH. This helps maintain blood volume so that our bodies don't become, don't have an increase in osmolarity. If there's a decrease in milliosmolarity, ADH is decreased, which helps reduce blood volume and concentrate our bodies. Basic actions, well, antidiuresis. It stops you from peeing. Antidiuretic is antidiuresis. It stops you from peeing. It helps maintain and retain water. It helps maintain the blood volume you have. It prevents you from peeing out the fluid in your body, which helps maintain MAP. It also has a minor effect of vasoconstriction. So both of these will help maintain blood pressure. Vasoconstriction increases TPR, which increases MAP. So I believe the way this hormone got its name was somebody discovered it and realized that it stops you from peeing, so they called it antidiuretic hormone. And around the same time, a different scientist discovered this hormone that caused vasoconstriction, and he called it vasopressin. And then a few years later, they realized that they had discovered the exact same hormone. How does it work? Well, vasoconstriction, it works on the smooth muscles of our circulatory system. And it also works on the distal nephron, the cells called the principal cells in your distal convoluted tube and in your collecting duct. And what it does is it puts more aquaporins in these tubes. So aquaporin, aqua refers to water, porins like a pore, like a hole. So it puts more channels for water to move through in these principal cells, which allows more water to flow back into our bodies. So you can see here, storage vesicles with aquaporins on it. It gets the signal from vasopressin. It tells these storage vesicles to put the aquaporins in the cell membrane. It puts the aquaporins in the cell membrane. H2O is able to move from the tubule lumen into these principal cells and back into our bodies. So hyperosmotic interstitial fluid drives water reabsorption. So what does that mean? Well, you can see here that the descending loop of Henle allows water to leave. Within the tubule, it's about 300 milliosmoles. Outside, where the loop of Henle goes down into, it's about 600, 900. The deeper it goes, the higher the osmolarity outside of the tubule. And what does water do? Water moves to dilute. So as this fluid flows through this descending loop of Henle, water moves to dilute the hyperosmotic interstitial region. And then as it comes back up through the ascending loop of Henle, water doesn't get reabsorbed, but ions do. You don't need to actively transport your water because of this osmotic gradient. Antidiuretic hormone. So what increases your release of other things that increase your release of antidiuretic hormone? Pain, stress, and trauma will actually also increase your production of or release of antidiuretic hormone. Also, some medications, some drugs. Morphine does, and so does nicotine. What decreases its effect? Alcohol. So drink a 6-pack, pee a 7-pack. Alcohol inhibits the ability of ADH to do its job. And so you don't retain water and you pee out a lot of water. So alcohol, people who when they drink alcohol pee a lot, and it's because of its interactions with antidiuretic hormone. Hyposecretion causes diabetes insipidus. So up to this point, every diabetes that we've talked about has been classified as diabetes mellitus. Type 1 diabetes, type 2 diabetes are both diabetes mellitus. Diabetes insipidus is caused by a hyposecretion of ADH. And repeat that. Type 1 diabetes is diabetes mellitus. Type 2 diabetes, diabetes mellitus. Diabetes insipidus is due to a hyposecretion of ADH. Some of these patients can pee 25 liters a day. That's insane. That's an insane amount of liquid. Aldosterone is our next hormone. So aldosterone stimulates sodium reabsorption. Sodium reabsorption. So where does aldosterone come from? It comes from the adrenal cortex. Basic actions is it helps retain sodium. And what happens when more sodium is brought from the lumen of our tubule system back into our bodies? More sodium is brought back in, well, water follows. And so it helps maintain water levels, which helps maintain blood volume and MAP. It targets the ascending limb of the loop of Henle. It increases the number and activity of sodium reabsorbers. So right here, ions reabsorption. It's increased by decrease in sodium concentration, decrease in blood pressure, increase in potassium concentration, and acidosis. Sodium reabsorption helps balance positive potassium and positive hydrogen ion secretion. This next one requires a bit of a story. So I'm going to tell the story a couple times, and I would recommend that you get to the point where you can tell the story also. There's a number of parts. It's all summarized over here in this image on the right. So angiotensin 2. Angiotensin 2. We don't start off with angiotensin 2. This story starts in our liver. Our liver is constantly producing angiotensinogen. Where have we seen this inogen before? Pepsinogen is the inactive form of pepsin. We can go back to the first test. Angiotensinogen is the inactive form of angiotensin. So our liver is always producing angiotensinogen. There's always some level of angiotensinogen within our bodies. Our blood pressure drops. We're going, all right, so that's the set. The scene is set. The scene is set. with angiotensinogen in our plasma produced by our liver. We're now jumping over to somewhere else. The JG cells in our kidney detect a decrease in blood pressure. JG cells in our kidney detect decrease in blood pressure, so they release renin. Renin converts angiotensinogen into angiotensin 1. Angiotensin 1 vasoconstricts. It vasoconstricts. Angiotensin 1 floats around our bloodstream and eventually will come to the endothelium within our lungs. And it will encounter an enzyme called the ACE enzyme, or angiotensin converting enzyme. Angiotensin converting enzyme. So angiotensin 1 encounters the ACE enzyme in our lungs, and angiotensin 1 is converted into angiotensin 2. Angiotensin 2 is a very potent vasoconstrictor. So major action, vasoconstriction. It also helps some with fluid retention by promoting ADH production. Helps some with fluid retention by promoting ADH production. It targets vascular smooth muscle, that's the vasoconstriction, and the hypothalamus, that's the ADH production. Renin is the rate-limiting factor within this. There's always angiotensinogen. The rate-limiting factor is the renin. Renin production is stimulated by a decrease in blood pressure, which decreases the stretch of JG cells. It can also be, the release can be stimulated by the macula densa and by the autonomic nervous system, the sympathetic nervous system. Atrial natriuretic hormone stimulates sodium secretion. So the three hormones we've talked about up to this point all help maintain blood pressure. This hormone is going to help decrease blood pressure. Atrial natriuretic hormone, ANH, is also called ANF, atrial natriuretic factor, or ANP, atrial natriuretic peptide. So hormone, factor, peptide. Source, well, atrial, it comes from the right atrium. When there's an increase in stretch of the right atrium, there's an increase in ANH production. Basic actions, it blocks sodium reabsorption. It blocks sodium reabsorption. If sodium is not able to be reabsorbed from the renal tubule system, it's going to stay in the renal tubule system, and water is going to stay in the renal tubule system with it. So that water gets peed out, it gets secreted. This decreases our blood volume and decreases our MAP. It targets the ascending limb of the loop of Henle, and it decreases the number and activity of sodium reabsorbers. Here is our summary chart for these four hormones. One thing I want to point out, proangiotensin is another name for angiotensinogen. Proangiotensin is another name for angiotensinogen. All right, let's talk about clearance. So clearance is a non-invasive way to assess renal function. Clearance is the volume of plasma cleared of a given solute in a given time. So you could talk about the clearance of glucose. How much plasma was glucose completely removed from within a given time? The volume of plasma cleared of a given solute in a given time. So its clearance is equal to urine concentration times urine production rate divided by plasma concentration. One thing I want to point out, So GFR, glomerular filtration rate, in these examples is 100. In other parts of this lecture, you saw it at 125. It's right around there. 100 to 125 is a good typical range. So let's look at this right here. This is inulin. So inulin is floating around in the bloodstream, and some of it gets filtered out with our plasma and moves into the renal corpuscle, which then moves into the renal tubule system. No inulin gets reabsorbed. No inulin gets secreted. Inulin is useful in a healthcare situation because it is not reabsorbed and is not secreted, but it does get filtered out. So if we can calculate inulin clearance, we can calculate glomerular filtration rate for that patient. So right here, so for any substance X that is freely filtered, but neither reabsorbed or secreted, its clearance is equal to GFR. So clearance is equal to GFR if there's no reabsorption and no secretion. With inulin, we're filtered, but then no reabsorption, no secretion. So if we can calculate the clearance, we can calculate the GFR of that patient. GFR is very important. There's many disease states where GFR is not normal, and you can use inulin to calculate that. So clearance is equal to GFR if it's not secreted or reabsorbed. Let's look at glucose. So with glucose is filtered out. It moves from the glomerulus into the renal corpuscle and renal tubules. Under normal situations, 100% of that glucose gets reabsorbed. Every glucose molecule under a normal situation gets reabsorbed. So let's punch in our numbers. Urine concentration is 0 because 100% was reabsorbed. Clearance is 0. Glucose is valuable. We don't want to pee out glucose. So we don't. We reabsorb all of it. If clearance is 0, there's two possibilities. One possibility is that what we're looking at is a situation like glucose, where the molecule gets filtered and then 100% reabsorbed. The other situation where we can have 0 clearance is if it never gets filtered to begin with. Think about proteins and red blood cells. Proteins and red blood cells don't leave the glomerulus. They stay in the bloodstream. If they don't ever get filtered, they don't get urinated out. So clearance would be 0 also. So if 0, it's either never filtered or it's filtered and completely reabsorbed. In this situation, we're looking at urea. Urea gets filtered out, becomes part of the ultrafiltrate, goes through the tubule system, and about 50% of the urea gets reabsorbed. Urea is partially reabsorbed. So if we punch in our numbers, we can see that the clearance for urea is 50 milliliters per minute, about half of glomerular filtration rate. So if you see a situation where clearance is less than GFR, you know there's net reabsorption. So urea gets filtered and reabsorbed. And so are amino acids and many other nutrients. Let's look at penicillin. Penicillin gets filtered, does not get reabsorbed, and additional penicillin gets secreted into the renal tubule system. So if we look at our clearance value for penicillin is 150 milliliters per minute. That's more than the 100 for the glomerular filtration rate for this patient. So we know because clearance is higher than the GFR that penicillin gets filtered and secreted. Filtered and secreted. Remember, just filtration is equal to GFR. It's higher than that, so it's filtration plus secretion. All right, everybody. That finishes it for renal physiology. If you have any questions, please let me know, and I will see you in the next section.